All right, so in these next 3 lectures, we're going to go over the peripheral nerve lesions table on the last page of the hand section of your book. And in each of these videos, we have a pair of unique hand presentations, and many of these are those famous claw presentations you hear about. These are very high yield for anatomy exams, very high yield for board exams, and so we want to go through each of them and make sure you got them down. And in each video, we go through a pair of presentations, and then at the end of the video, we compare the 2 presentations so that you're able to distinguish both of them. So in this first video here, we're going to cover the wrist drop and the Klumpke claw. All right, so we're going to go through those lesions in your book, and we're going to look at the muscle deficits in these lesions, and then what you'll see on physical exam, and then the signature signs, so the claw or some of these other signature signs that you'll see, and then really tie it all together and how that localizes the lesion. So first, proximal radial nerve injury. So just to review the anatomy here, so this is a posterior view of the upper extremity. Here's the shoulder here, the glenohumeral joint is in here, here's the deltoid muscle here. You have the radial nerve emerging out here when it comes off the brachial plexus, goes through this radial groove on the posterior aspect of the humerus, comes down through here, and then travels over the lateral epicondyle, and then travels before it splits into the deep radial nerve and the superficial radial nerve in the forearm. And then you can see it here. Here's a close-up view of the deep traveling through the extensor compartment. And then you can also see here at the elbow where the radial nerve is bifurcating into that superficial radial and then the deep branch of the radial. Essentially what it means when we say proximal is that it's not at the wrist. It's not a wrist injury. It's going to happen much more proximally, usually typically towards the elbow or even more proximal than that. So if you have a proximal radial nerve injury, you're going to definitely lose your forearm extensor compartment. Now, if you remember when we talked about midshaft humerus fractures, the radial nerve at that point, when it goes through that radial groove, it's already given off its innervation of the triceps. And so you're not going to lose elbow extension here. So, whether you're up in the midshaft or you're just here below the elbow, what you're going to affect is the radial nerve innervating all of these extensor muscles in the forearm. So here's, the extensor compartment here. There's many layers, as we talked about in the forearm muscles lecture. So really, the radial nerve is responsible for all these. So if you have a radial nerve lesion at this point, it's going to be right before it goes down into the compartment and innervates all these muscles. So you're really going to lose all the innervation to the extensors of, the wrist and the fingers and in the hand region. So what you'll see on physical exam is you'll see loss of wrist extension because of all those extensor compartment muscles, loss of thumb, MCP, and ICP extension, so metacarpophalangeal joint and intercarpophalangeal joints, the extension of that, so they won't be able to extend their thumb essentially, loss of digits 2 through 5, so the index through the small finger, MCP extension, so they'll lose extension at that joint. They'll still have some extension at the PIP and the DIP joints because you remember the lumbricals, even though they originate on more the palmar aspect, they wrap around the fingers and insert onto the extensor wad, and so in that sense they help extend the PIP and DIP joints. So you'll still have a little bit of extension there even though you've lost these extensor compartments. Now normal is, these are all going to be flexion muscles in the flexor compartment, which are more so median nerve. You're going to be able to flex your thumb just fine, and the distal interphalangeal joints as well, because that's another flexor compartment muscle, will be able to be flexed as well. So the signature sign here really is the wrist drop. So you've heard of wrist drop. You can get its signature sign of a radial nerve injury. And really the only place you would not see a wrist drop is if you had more of a distal radial nerve injury. So if it happened here more at the wrist, same concept with the midshaft humerus fracture with the radial nerve. By the time you get to the midshaft of the humerus, it's already innervated the triceps. Same concept here. By the time the radial nerve has gotten to this point, it has already innervated all the extensor muscles of the forearm. So even if you cut the radial nerve, you're still able to innervate all the extensor muscles in the forearm. So you're still going to have wrist extension, finger extension, thumb extension at that point. So that's the big difference between a proximal and a distal radial nerve injury. So proximal radial nerve injury is signature sign, you're going to see wrist drop. And quickly, the sensory loss for these patients, since it's a radial nerve injury, it's going to be in the radial nerve distribution. So it's going to be on this dorsal aspect here in the first 3 fingers, except minus the tips of the fingers and the thumb here. All right, so moving on to the next lesion in the table is the lower trunk brachial plexus injury, also known as Klumpke's palsy. And from now on, we'll just refer to it as Klumpke's palsy because that's typically what it's referred to as. And so what this is if you remember, is a lesion of the inferior trunk. So C8 and T1. So it's primarily going to affect the ulnar nerve because the ulnar nerve is a direct extension, off the medial cord, which comes off this inferior trunk here. It's also going to affect the median nerve because this medial cord coming off here contributes, half of the fibers to the median nerve here as well. So what are your muscle deficits going to be? The muscles affected are going to be your lumbricals, all four, because if you remember, lumbricals 3 and 4 are your ulnar. Lumbricals 1 and 2 are your median, and since you've affected both of these nerves, it's going to be all 4 lumbricals, versus if you had affected one, if one nerve was affected and the other one was normal, then only half the lumbricals would be affected. But in this case, all 4 are. The other thing that's affected is, since ulnar nerve is affected, you're going to lose the interossei. So these are ulnar nerves. So your dorsal interossei, or your DAB muscles, so abduction, the dorsals abduct the fingers, and then you have the palmar or the pads for adduction, so they adduct the fingers. So you're going to lose these two sets of muscles as well. So what's the physical exam going to look like? So you're going to have, you can see it here, there's a great picture, is the Klumpke claw. That's your signature sign. So how do you get to that? So you have loss of digits 2 through 5 MCP flexion, so metacarpophalangeal joint flexion. You can see that here where the joints are extended because you've lost flexion. Remember that muscle equilibrium, flexion and extension at a resting position are in equilibrium. The problem is if you've lost that MCP flexion, the extenders, the extensor compartment muscles are going to act unopposed and pull the fingers out and extend them. Next, loss of digits 2 through 5 PIP and DIP extension. So both of these are a result of the lumbricals 1 through 4. So you see it in all 4 fingers versus 2 if it was just one of the nerves. And so it's all, since both nerves are affected, both median and ulnar, that's why you see all 4 affected. So then loss of digits 2 through 5 PIP and DIP extension. So you've lost extension, so then the flexors of the fingers are going to act unopposed. So you can see that, here's your PIP joint here, they're flexed, and then here's your DIP joints right here, and they're all flexed because the flexors are acting unopposed. There's no counterbalance force. So here we go through the other muscles that are affected. So dorsal interossei, same thing, you're going to lose this extension here. Palmar interossei, the same thing. And these muscles, they assist with PIP and DIP extension. So the interossei muscle assist with that. So you're really going to have very weak extension of these joints. And in fact, one thing I really want to point out here is that extension of these joints, the PIP and the DIP joints, these are mainly carried out by the lumbricals with some assistance from the dorsal interossei and the palmar interossei. The extensor compartment of the forearm, those muscles, they don't really have much input or much contribution to extension of the PIP and DIP joints. So that's why you see here, since we've lost extension at these, that the flexion predominates in the equilibrium. There's no balancing force because these are lost, and then you could think on the extensor side of the forearm, those muscles don't really, they contribute to MCP extension. They're the main muscles that contribute to MCP extension, but they are not significant extenders of the PIP or the DIP joints. The main extensor of the PIP and DIP joints are the lumbricals, and then with the dorsal interossei and the palmar interossei. So that's why you get this presentation where the fingers are flexed at these. So I want to make that really important because that's something that can be confused because you think of the extensor compartment of the forearm as extending the fingers when really it only extends at the MCP joint. Extension at these more distal joints is lumbricals and the interossei. So what's normal is digits 1 through 5 MCP extension. So those are the extensor compartment of the forearm. Those are innervated by radial nerve. Radial nerve is not affected in this lesion at all, so that's going to be completely normal. You're going to be able to extend the MCP joint, and that's why these are extended out like this. Digits 1 through 5 PIP and DIP. So these are forearm flexors, which are median nerve. Now you may be asking, I thought median nerve was out. Now, yes, they're to a certain extent. Now, if you remember, you have, if you draw your M here like this in your brachial plexus, so you have your median nerve coming in like this, right? And so then you have your cords like this. You have your medial cord here and your lateral cord up here, and then it's, this is contributed by the superior trunk and this is coming by the inferior trunk here. Okay, now this half of the fibers going to median nerve are gone, but these are still intact. You still have fibers coming in from the superior trunk aspect and the lateral cord. And so the median nerve is not entirely gone. So it's not like any function controlled by the median nerve is gone. Now what you need to understand here is that the fibers coming from the inferior trunk that go through the medial cord and then go into the median nerve, these fibers in the median nerve are more responsible for the hand muscles. So the lumbricals, the thenar eminence. And so these are going to be more affecting. That's why you see the symptoms more so in the hand. And then these fibers that come from this end, from the superior trunk that go through the median nerve, these are the ones that are innervating the forearm flexors. So you still have intact forearm flexor muscles that will, act on the joints of the fingers and flex the fingers. So that's why you have this presentation. That's why you have loss of the lumbricals, but at the same time you still have intact. And it all goes back to the anatomy of the median nerve of the brachial plexus, and that's why it's important to understand that it's receiving contributions both from the superior trunk and the inferior trunk. In this case, the inferior trunk is out, so you've lost these fibers that are going through to the median nerve and go on to innervate the hand. And if you think about it, that makes sense. The ulnar nerve is coming off. The fibers originate from the inferior trunk as well entirely, and because this part right here would be the ulnar nerve, this lower part of the M. And the ulnar nerve is entirely responsible for a lot of the intrinsic muscles of the hand. And so it makes sense that, the fibers controlling the hand in the median nerve are coming from the same region of where the fibers in the ulnar nerve that are controlling the hand originate from. And so that's the way you can distinguish that and understand that while you have loss of median nerve hand function, you still have median nerve forearm function. And then as a result of that, that's what gives you the signature Klumpke claw. We've paired each of these injuries because they have somewhat similar presentations, especially in the hand, and we want to make sure you understand the difference between those two. These two aren't quite as similar as the next two pairs, but it's still worth making a comparison so that you can differentiate these. So an proximal radial nerve injury, now remember, really what we mean is that it's just not a distal injury. So it's not here at the wrist. It's, more so above here affecting forearm muscles. And so at a proximal radial nerve injury, it's a radial nerve injury, obviously, and then you're going to have loss of wrist and finger extension. And then in a Klumpke's palsy, it's median and ulnar nerves are affected, and then it's loss of MCP flexion. So then that's why you have these extension out like this. And so, but another thing is that with all of these hands, this is kind of a big thing, with all of these hand presentations we'll go through, these different claws and such, is that if you want to make particular note that if it's occurring at rest or when someone's trying to make a fist or do some other kind of motion with the hand, because that's how you're going to really be able to distinguish them. And that would be something that they would tell you in a question stem, is either this is what the patient's hand looks like when they're trying to make a fist, or this is what the patient's hand looks like when it's at rest or when they're trying to extend the fingers out. And so that's really important. And so what's key here is that both of these are at resting position. So even though they're very different presentations visually, what's important to note is that they're both at rest. All right, so that's wrist drop and Klumpke claw. In the next video, we're going to compare ulnar claw and the hand of benediction.